Thank you so much to the organising committee for inviting me to give this lecture. Freezing of gait, is there anything that really helps? It's controversial, and I guess it's really quite close to our hearts, given the degree of problems that we see with freezing of gait in Parkinson's. This is work we published a few years ago, suggesting that basically most people with Parkinson's disease will get freezing of gait as the disease advances. It impacts on quality of life. It ends up putting them into a nursing home because of falls. So it's a really big problem, and we know we don't have any fantastic treatments. Otherwise, I wouldn't be giving you this lecture. But undeterred, here we go. We know it's complicated and we don't understand it. This is a nice review that put together with a number of people from the field, reviewing the clinical, the imaging, neurophys, some of the genetics, trying to understand, get a handle on freezing of gait. We don't understand, it's going to be very hard to treat it. And people have tried to put forward models for what's going on in the brain, the pathophysiology of freezing. Some of them are a bit more developed with more data than others, but things like the threshold hypothesis, where the gait breaks down because of asymmetry between the two halves of the brain, decoupling between gait and balance, pausing movement, the cognitive theory, where a bit of overload, but very much close to my heart, of course, is this sort of interference, which is the crosstalk model, or the neural reserve hypothesis of freezing, which basically states that there's decreased neural reserve across segregated circuits. So we've got competing yet complementary pathways, and when they crosstalk in a depleted striatum, you get an overwhelming activity that can't cope, and there's a freeze, and that results in a lack of movement going out through the brainstem to the legs. But of course, you can reset by concentrating sort of goal-directed behavior, focusing all of your attention on one thing. And so if we look at that in sort of graphical fashion, when you overload the thinking, the moving, the worrying, so cognition, motor, and limbic pathways going through a depleted striatum, you can get a freezing episode where the feet won't move. And then if you focus on just moving, such as cueing, stepping over something, you'll get back to your Parkinsonian gait. But if we look at the neuroanatomy underpinning that, these are sort of side by side what should be happening. But in Parkinson's, where the striatum is depleted of dopamine as the primary neurotransmitter loss, you'll see we end up with increased activity in the inhibitory outflow nuclei of the basal ganglia, the GPI and STN. So essentially, when you lose dopamine here, you end up with increased inhibitory activity in the GPI, which shuts down the thalamus, and therefore you get less communication to the cerebral cortex. There's also the hyperdirect pathway going to the STN, and that leads to these inhibitory signals passing down through the brainstem, the mesolocomotor region, and down to the central pattern generators in the spinal cord, and resulting in a freezing episode. The basis for this presentation, I'm going to take really around this paper that I wrote last year with Kathy Kui, and it's sort of basically looking at the therapeutic strategies that we have and what we might do with them. And so sort of key steps towards developing effective therapies for freezing of gait, and if you like, looking at those therapeutic approaches. And what we put forward in the paper is that one of the big problems we have is around definitions. So if you take the definition of freezing itself, which arose from the first workshop on freezing of gait, the international workshop in Washington, it really stated that freezing was an inability to walk despite the intention so to do. But there were some nebulous terms in there, like it was a brief interruption. It was an episode. I'm not sure what brief is. I'm not sure what defines the start of an episode and the finish of an episode, especially when you've got someone who's got really interrupted gait, and a marked reduction in the output. So no objective measures there for, if you like, researchers or clinicians to hang their hat on. So we need to look at this. And similarly, we need to look at the way we measure the phenomenon of freezing. Are we going to use qualitative rating scales? Are we going to do semi-quantitative, where we have people doing gait assessments, but we score them on a sort of 0 to 4, are they good, are they bad scale, or something really quantitative where you might measure from a video the amount of freezing they have, or measure another biomarker like the brainwave signals, for example. So we really need to sort these things out, and this is a challenge for those of us in the field. The other thing we need to do is investigate the data we already have. There's a lot of people around the world who've got data on freezing of gait. We need to put it together. We need to be more collaborative. We also need to look at non-gait paradigms, because, of course, people freeze doing other things with their hands. They might do stepping in place. And we need to look at ways of measuring that. So things like virtual reality, which I'll talk about a bit later on, paradigms that involve upper limb movement. All of these things might give us extra information about what the pathophysiology of freezing really is. And then the big one, how do we measure it? Do we have to do video assessments? Can we get some automated scoring into those video assessments? Do we use wearable technologies? And really, I guess the big problem we have is that most of this stuff happens in the clinic, as opposed to where most of the freezing happens, which is at home. Although that is the nature of clinical trial work. We often assess patients when they come to the clinic rather than when they're at home. But these are things that we need to develop further if we're really going to have effective therapies. And if we take that one step further, a lot of the trials I'm going to show you today rely on things like questionnaires. And this is work we published now a few years ago, looking at people with freezing, doing a standardized timed up and go assessment where we use triggers for freezing, like turning, going through narrow gaps, going through a start hesitation. And we actually measured the amount of freezing they had using video scoring. And what we showed was that in actual fact, when you compare the objective amount of freezing, whether it's the percentage of time spent freezing despite the intention to walk, or the number of freezing of gait events, the freezing of gait questionnaire and the new improved, or maybe not so improved freezing of gait questionnaire don't seem to correlate with that. Now, of course, those questionnaires are looking at the last month or so rather than what's happening in the clinic. But of course, we're basing a lot of our trials on these questionnaires and not focusing on actual objective measures. And there's that dichotomy between, well, what's going on at home versus what goes on in the clinic that we can actually measure. And then, of course, we need to get to treatments. And so, these are really important elements for us. And just to sort of bring that all together, this is a paper that's in press again from a number of luminaries in the field of freezing and myself, a bit of it also ran. But the focus of this paper really says we need to standardize those definitions and the ways we measure freezing of gait, because otherwise, how will we ever get to do clinical trials that are going to be accurate and inform us in our practice? We need to be able to integrate data from existing sources, but also across multimodal, so imaging, neurophysiological, clinical biomarkers, whatever it is, neurocognitive, whatever. We need to be able to integrate those. And that's not going to be easy because most of us are clinicians who aren't great with big data. So we're going to need to see more interaction between clinicians and data scientists, computer learning, all of those things, which I think are going to be really important for handling this. So what about those therapeutic strategies? And this is going to form the rest of my presentation. And we're going to cover things like physical rehabilitation, pharmacological strategies, surgical strategies, so essentially deep brain stimulation, non or less invasive brain stimulation, through things like transcranial magnetic stimulation, and we'll see some other techniques too. Neuropsychiatric approaches, so targeting cognition and psychiatric features. So starting with the big one, physical rehabilitation, there are a number of strategies that people have been looking at, and this is not an exhaustive list. I've just pulled out some literature, but action observation training, which is where patients with freezing not only do some physiotherapy, but also will be watching videos or imagining techniques that can actually break the freeze or reduce the amount of freezing that they have. Treadmill training, and you can do lots of things on treadmill, adjusting split belts so that the feet work at different speeds. You can do obstacles, you can use virtual reality, get people stepping over things that aren't really on the treadmill. Obstacle training, and this is an example of aquatic, but essentially, again, stepping over things, triggering that focus of attention onto your gait. Curve walking training, similar thing. Supervised slackline training, again, maybe reducing anxiety because of the way that the thing is devised. And then, of course, what every patient should be doing, home-based exercises to see whether they can impact. One of the other features that I didn't cover there is cueing. Patients are very aware of cueing, and there are obviously different types of cues. So the visual cues, such as lines on the floor. There's a laser light device that puts a laser beam on the floor, and also just simple things like sellotaping a drinking straw at right angles near the bottom of a walking stick so people can step over it. Auditory cues, so like a metronome or a beeping or some other form of auditory cue, like a voice, and tactile cues, sort of vibration. So in the insoles of the shoes, having something that if you were going to stop walking would trigger you to focus your attention and then start walking again. But of course, we know from work by Alice Neubauer that the benefits of cueing on freezing are modest, so about a 5% reduction. They're unsustained because you need constant cueing and patients habituate and they hate it. It's a bit like being on your driving test all the time where you have to drive, looking at your mirrors, big exaggerate. It takes a lot of energy to walk using volitional movement, cueing into things that are not, if you like, subcortical automatic. And we don't have any good data on the commercial devices that patients are currently paying for, which you have to say, well, I don't know that we should be encouraging our patients to do that. In terms of reviewing the literature, there are a couple of meta-analyses out there which are really from the last couple of years, and this is wonderful work showing 19 studies, analysing 19 studies, over 900 patients, and what they found were similarities. So session duration, about 45 minutes to 60, it doesn't matter what kind of exercise we were talking about. Similar number of sessions a week, so it's not as though every day or just once a week. That's a 2 to 3 times a week thing. Home-based interventions seem to show more promise. Perhaps that's because of people being more compliant, less involved to get into the clinic. And of the techniques that were reviewed here, action observation and treadmill training seem to have the most significant effect sizes on reducing freezing. So I think there is good evidence to help us with the rehabilitation strategies. And this is more recent work just published in February 2022, evaluating 46 days, over 1,400 patients, looking at a meta-analysis of freezing. And this is, if you like, the take-home. This is a regression analysis looking at the standardized amount of freezing people got following each of these rehabilitation strategies. And you'll see again some themes. So training on a treadmill is there, but also obstacle training and general exercises seem to be effective. So I think we should definitely be encouraging our patients to take on these strategies anyway. What about pharmacological approaches? Well, we can run through the neurotransmitters and systems, so dopaminergic, adenosine, cholinergic, noradrenergic, glutamatergic. I won't go into depth on serotonergic or cannabinoid, but I will touch on a bit later. So dopaminergic, we all know that more freezing happens when patients are wearing off. So anything that improves wearing off, so the MAO-B inhibitors, the dopamine agonists, the COMT inhibitors, for example, are all going to be helpful in reducing off periods. On freezing is trickier, and there's this sort of levodopa paradox. Can some patients have more freezing because they're on dopamine and they're getting better effects? And this is much more difficult and challenging to get your head around. But there is a little bit of data out there to suggest that if you use the levodopa carbidopa intestinal gel, but use it for 24-hour periods, so not just during the daylight hours, perhaps this can reset some of the striatal maladaptation that's going on that might be triggering freezing in the on state. And this is work out of Westmead in Sydney, led by Victor Fung's team. Adenosine, so there's some work in istradefylline. This is a very small study, open label, and we're talking about a selective adenosine A2A receptor antagonist here with 2 doses increasing after 4 weeks. Really looking at things like self-report questionnaires and some Gait rhythmography. And the study does suggest perhaps that there's a reduction in freezing of Gait in that middle panel, but one has to be very wary about the placebo effect in these patients, although there were some improvements in the objective Gait measures, although this isn't specifically freezing. What about the cholinergic system? Well, this is work from Emily Henderson over in Bristol, looking at rivastigmine, a cholinesterase inhibitor at variable doses, 32 weeks. And there were improvements in gait and balance, so reduced falls, improved step variability. And during the last month of the trial, reduced freezing was reported. And this has led those investigators to start another trial, Chief PD, which is ongoing to look whether cholinesterase inhibitors may offer more in relation to gait. And I think they'll have some more specific markers in there for freezing. Atomoxetine is a selective noradrenergic reuptake inhibitor, and there are a couple of trials out there. This one from Joe Jankovic, I think there's only 5 patients in it. This one from Revelta, I think there's only 10 patients in it. Very small numbers and no obvious benefit. But I don't know that we can throw the noradrenergic pathway out, especially given some of the data that's arising, correlating the locus coeruleus with freezing of gait. So I think we have to keep an open mind on the noradrenergic system and get better trials, bigger numbers. How about methylphenidate? So this is an approach of targeting dopamine and noradrenaline reuptake, really targeting the amount of dopamine and these triggers in the striatum and the prefrontal cortex. And this is work published now by Carol Moreau a number of years ago, targeting patients who had already STN-DBS and had some freezing. Relatively reasonable numbers, but what they showed, although there was a reduction in freezing, you've got to really bear that in mind with the fact that there's a very small number of episodes in the first place. So, a significant reduction from 6 to 5 or 4 to 3, you have to keep that open mind. And of course, the amount of adverse events in the methylphenidate group might limit the use of this medication approach. What about intravenous amantadine, or amantadine as an approach looking at the anti-NMDA, or sort of reverse the pathological glutamatergic overactivation in the brain? This is work from Seoul with Byung-Shok John, BJ, and Ji Young Lee, looking at intravenous amantadine given over 5 days and studying patients at baseline, day 5, and a month later. But they, again, showed no improvement in freezing of gait, but only on questionnaire. What about deep brain stimulation? So we're going to move from pharmacological into surgical. And this is retrospective analysis of the early STIM data, which basically showed that those patients who had deep brain stimulation compared to those who had best medical therapy did show a reduction in their freezing of gait. Though obviously this, I suspect, is mainly carried by an improvement in the off freezing, because we all know that DBS improves the amount of good on time. But it is important to recognize the fact that although we don't usually recruit patients with bad freezing into deep brain stimulation programs, it does seem that those patients who converted from being freezers into non-freezers was significant and certainly important in the deep brain stimulation group. So I don't think that we should be forgetting the fact that deep brain stimulation may be beneficial for freezing of gait per se. With that said, many of us in the field have looked at the literature as involved with reducing the frequency of DBS stimulation, so not really stimulating at over 100 and 130 hertz or something similar, but taking it down like 60 hertz. And this is a meta-analysis that suggested actually this may be a favorable technique, but I have to say most of the patients I've done this with seem to have habituated and they've lost control of other features. And indeed, this study did show that patients, although they improved their freezing, had more in the way of tremor, and often they can't sustain the low frequency setting. So something worth trying in individual patients, I suspect. And what about targeting other structures, not just the STN? Well, this is the debate about the pedunculopontine nucleus, and this is a meta-analysis suggesting that stimulating the PPN can be effective for freezing of gait. But again, I think what happens is that you do see patients who can't tolerate that because their other symptoms get worse. And this is a video of a patient that I assessed for Paul Silverstein here in Sydney. This is a patient with PPN DBS, and this is with his stimulator switched off, and you can see quite clearly a significant amount of freezing. And when we turn his stimulator on, you'll see an obvious improvement, but he just couldn't tolerate the other deterioration of his Parkinson's disease. These approaches I've talked about so far are using continuous stimulation. This is nice work from Helen Bronte-Stewart, really saying, well, what about on demand? If we could see a signal that suggested freezing, a surge in beta activity, maybe if we just treated this, we could actually reduce the amount of freezing on demand. And this is a single subject. It's not actual free walking gait freezing, but this is stepping in place. And you can see the improvements when they adjusted the stimulation to kick in when the patient needed it based on the signal in the brain. And this is in keeping with some of the research work that I've done here in Sydney, using a virtual reality paradigm in the operating theatre while people are having their STN DBS put in. There's a screen at the end of in front of the patient's face, that pedals at the end of the bed, and they can actually navigate this three-dimensional environment. We've published this many times now in imaging, but here we published it listening into the firing patterns in the STN and showed that there was a surge in beta activity just before a freeze, And that looked different to the surge that you see with voluntary stopping. So with the advent now of these devices that can both stimulate and sense, I think this is a possibility in the future that we might be able to tune into an on-demand system or a closed-loop system of DBS that, of course, would open up the market for who should get DBS in the future, given that freezing isn't usually a very strong indicator. What about non-invasive brain stimulations? This is transcranial magnetic stimulation. This is a meta-analysis suggesting that probably not that effective, or this one a little bit effective. Sorry, not that effective, but there's another meta-analysis here suggesting that actually it may be effective. And I think the problem with transcranial magnetic stimulation is the variety of the paradigms and the severity of the patients and how it's all measured. So I think we can't close the door on it, but it doesn't look as though it's a golden bullet. Non-invasive vagus nerve stimulation. This is a study out of India recently, using a stimulator applied over the neck region, trying to catch the vagus nerve, and a sham condition and a stimulation condition. And these authors reported some improvements in gait parameters, but no real significant improvement in self-reported freezing of gait, but certainly an area that is worthy of further evaluation. Spinal cord stimulation got a lot of attention a few years ago when I think there were some reports out that it was a very effective therapy for freezing, and certainly patients got excited about it. But over time, I think the literature hasn't really borne that out. So I think we're probably at a stage where I don't think many centers are encouraging patients to have spinal cord stimulation when they're freezing. Finally, what I want to tap into is the idea of neuropsychiatric targets for freezing of gait, based on the fact that we know that patients with freezing seem to have some neurocognitive deficits as well as psychiatric deficits. So effectively, this is work that tapped into the fact that patients with freezing seem to have attentional deficits, so dysexecutive phenotype. And what this study did from my team was to use a randomized control trial between those who got cognitive training focusing on attention versus an active control who got just educational about freezing. And what this study actually did show was that there was an improvement in real percentage time spent frozen. So not some self-reported questionnaire, but there was a reduction in freezing in those people who had the cognitive training, but only when they were on medication, suggesting that to improve cognition and freezing, you probably need a dopaminergic basis to try and salvage that striatal dopamine depletion. So again, a non-invasive approach that might be useful. And then finally, an area that really hasn't been tapped into is the increasing awareness that patients who develop freezing seem to have higher rates of anxiety. So in actual fact, this seems to be a predictor of those patients who go from non-freezer to freezer. And certainly what we haven't seen yet is intervention studies looking at things like serotonergic or cannabinoids in patients who aren't freezing, following them longitudinally to see if they delay the time before they develop freezing because we're ameliorating anxiety, or indeed treating people who are freezers with those approaches, or indeed non-pharmacological approaches such as cognitive behavior therapy. So there we go, an absolute romp through the treatment of freezing of gait. I think it's fair to say we don't have a fantastic cure for freezing of gait, but there are certainly lots of avenues for us to pursue. So in summary, we know it's a big problem. We need to understand the pathophysiology, and we need more standardized definitions and measurements so we can actually take them into more robust clinical trials and develop effective therapies, either from drugs we have or drugs that are novel. And with that, I'll thank you for your attention. Put up a slide of the team who do all the hard work, allowing me to come and give these lectures. This is a photograph from the 200-year anniversary of an essay on the shaking palsy. Thank you very much.